Hello friends, this is a case of suprapubic incisional hernia, and this patient has a small 2 centimeter hernia just above the upper border of pubic symphysis. Because this patient has gone 2 times cesarean section, and after that she has developed this incisional hernia. Now we will enter through the Palmer's point, and problem of these cases is that you cannot do IPOM because you cannot cover the pubic symphysis and the bladder with the intraperitoneal only mesh, otherwise bladder fistula will happen. So here we should try to distend the bladder, and the bladder should weigh down. So a Foley's catheter is introduced, and now we are distending the bladder with the 300 to 500 cc of methylene blue diluted normal saline. So once you distend the bladder, you can easily find out the delineated dome of the distended bladder, and once you will make a preperitoneal pocket, the bladder will weigh down. Now this 4 centimeter above the delineated dome of the distended bladder, preperitoneal space is started making it, and that you can do by sharp incision, maybe scissors or harmonic, and it should be the 4 centimeter above the dome of the distended bladder, in between both the medial umbilical ligament. You should not go lateral to the medial umbilical ligament to prevent the injury of inferior epigastric vessel. Here in the middle you can see the median umbilical ligament, that is obliterated urachus, and either side you have the 2 medial umbilical ligament, and just lateral to the medial umbilical ligament there is inferior epigastric vessel. So after giving this incision, now rest of the preperitoneal space will be formed by the blunt dissection. You should not use a sharp dissection. So this is done now. Now you can take the harmonic out, and with the 2 atraumatic grasper you can make this preperitoneal pocket. So this is all blunt dissection, and due to gravity bladder will drop down, and then you can reach up to the pubic symphysis bone. Here we can see it is reaching to the pubic symphysis bone, and either side of the Cooper ligament also will be visualized. That is also called as lighthouse. And this is anterior wall of the bladder, which will be bluntly pushed down, and here the pneumoperitoneum will help you because gas will enter into this suprapubic preperitoneal pocket, and you can easily separate the peritoneum from the anterior abdominal wall, and this will be in the space of radius, and these are the small hernias on the anterior abdominal wall. Now this is over, and after that you can put the mesh. Here we will use the ProVisc 3D. This is the inferior epigastric vessel either side, which you can see. So here we are planning to use ProVisc 3D polyurethane mesh. So this is a dual mesh which is made for intraperitoneal application. It has 2 sides, one layer is polyester, another layer is polyurethane. Polyurethane is blue color, B for bowel, B for blue, and this blue color will be towards the anterior, towards the viscera, towards the bowel, and this white color towards the anterior abdominal wall, and you should push it up to the pubic symphysis bone, and after that you will fix the intra-abdominal part with the tacker. And the suprapubic part you can fix with the Cooper ligaments, so that it will cover the every defect up to the suprapubic area. And now this peritoneum of the bladder will be fixed with the mesh together with the anterior abdominal wall. But remember, only peritoneum. Accidentally you should not fire the trocar over the bladder. So this is the peritoneum of the bladder, which you will support over the anterior abdominal wall and fire. This is at the level of the median umbilical ligament, and then again you will fix it, but remember, always you should fire medial to the medial umbilical ligament. Here our mesh is little bigger than the required size, but it's okay, and it will be fixed completely, so it will be not affecting the distension of the bladder, and this mesh will strengthen all the suprapubic hernia. This is absorbable trocar, so it doesn't have problem, it will get absorbed after some time. Now here one more will be fired, but take care that it should be medial to inferior epigastric vessel. So this is now over, and now slowly the bladder will be deflated. Now you can open the clamp of the Foley's catheter and bowel will be deflated, and you may see the color of the saline coming out should not be red, and if you want you can perform a cystoscopy to just check the integrity of the bladder. So this way most of the suprapubic incision hernia can be performed, and how much you will make the pocket, that depends upon the size of the hernia. Here there was a very small hernia, so that's why a big pocket was not formed. So thank you very much for watching this video. This patient doesn't want any baby now, because if again cesarean is required, then the mesh has to cut. So we have done tubectomy also. So this is ligature, and just 2 cm lateral to the cornual end, both the tube was cut with the ligature for sterilization purpose. So again, because patient family was already completed, you can see there is a small fibroid also on anterior wall of the uterus, but because patient is already 40 plus, so it is not necessary, because after few years he will go into the menopause and this fibroid will shrink. So thank you for watching this video. Have a nice day.